what symptoms we get when we have a ACL tear. This is the ACL. So ACL is a ligament which connects the upper bone femur to the lower bone tibia. ACL. This is the ACL. Get damaged, then we get instability. Instability means you can walk normally, but whenever you are going to do a long jump or change of direction, or if you are uneven surface walking on it, then you feel that your knee is not stable, it is giving away. This is going to damage your knee further because the constant instability, the osteoarthritis will set in early. So surgery is important, beta. Without surgery, the knee will get more and more damage. Your meniscus is also torn. When the meniscus is torn, then it will get more damage. There is a one femoral damage here also in the cartilage. It is known as contusion. So sometimes the contusion heals by its own, femoral contusion. Sometimes we have to see if the cartilage is damaged or not during the arthroscope. Mostly when you go for a surgery, this happens in 99% of the cases, that the people make ACL either from the hamstring or from the peroneus longus. So in one knee we can take two hamstring. The hamstring tendon are long and thin, so we have to make it strong. So we double it and we quadruple it, and we put a button on the top, and this is the 4-strand ACL. We start with the arthroscopic surgery. The old ligament will be taken off. I will do one hole on femur and one hole on tibia. So this hole will be of 7 to 8 mm in diameter. Why? Because 4 hamstring tendon makes 7 to 8 mm diameter only. Then we put the graft. The button will come on the femoral side and a bio screw will come on the tibial side. After this, if you do MRI, yes, grade 1, grade 2 tear can show in the MRI scan. Why? Because they are 4 strands. 4 dhage hai na beta. They are 4 strands. So in MRI, unless until they become one, there is some signal intensity in between these two fibers, which can a radiologist can diagnose as grade 1 or grade 2 tear, but this is normal. It is not torn like this. It is split. So that's why after the surgery, if grade 1 and 2 signals are coming, and if there is no anterior translation of tibia, then we are fine. Why I am saying your ACL surgery is fine? Because if you see your ACL, here is your ACL. So there is some signal intensity here, which is grade 2, but it is not torn like this. The orientation of fibers are vertical, almost vertical like this. This is a good sign. It is not lax. Second thing, if I draw a line from the anterior femoral cortex, the tibia is behind. So there is no anterior translation also. So ACL is good and it is not lax, it's tight. That's why I'm saying everything is fine. But there is a lot of fibrosis here. Why the fibrosis developed after the surgery? Because the rehabilitation was not good. You need to do exercises from day one under the guidance of a sports physiotherapist. So what you need for a physiotherapy is a gym and a sports physiotherapist. The combination of gym and a sports physiotherapist are rare in India. But this surgery has a failure rate of around 20%. Why? Because this ligament is going to be weak for 1.5 months. It is not joined to the bone. So for 1.5 months you will. So 6 weeks are rest. इसमें आता है. Why? Because it is not united with the bone yet. So there will be a brace, there will be a walker. You can't bend your knees completely. This develops a lot of fibrosis here and can lead to knee stiffness. इसलिए knee stiff हो गई. After 6 weeks you can walk. Slowly bending will come. So within 2 months you will be fine. The running will only start after 6 months. Why? Because there are 4 strands. It will become one, then you can run. So it will take around 6 months to make the ligament strong. It is known as ligamentation. From tendon to ligament, it takes that process. Once we start with the running, then we start the late rehabilitation. Agility training, balance training, drills. When we do late rehabilitation, then the nerve endings will grow and this ligament will become strong for life. So back to game is around 9 months. So that's why 4-5 months of rehabilitation is still there. Early mid rehabilitation and late rehabilitation is pending in you. But this surgery doesn't happen in any European countries or American countries. They have stopped it. Why? Because everything is changing. So what surgery we are going to do now is this. We will do all inside ACL reconstruction using quadriceps tendon, internal brace and LET. We will going to discuss that why quadriceps tendon, why all inside, why LET and why internal brace in all the patients. I use quadriceps tendon because it has lower re-rupture rate in every study. So this is more stronger for ACL. ACL बनाने के लिए सबसे strong है बेटा. अब this एक ही निकलता है. So there will be no grade 1 or grade 2 intensity after the surgery. So psychologically better रहता है. But re-rupture rate is also there in hamstring. It is less in quadriceps in every study. Quadricep tendon has a lower re-rupture rate than hamstring. There is a New Zealand registry, the same thing, that quadriceps and patellar tendon has lower re-rupture rate than hamstring. These are more stronger grafts. This is 40,000 patient study in. This is a Swedish study. Then when the surgeon experience is high, if the patient is a sportsman or if there is an MCL injury with the ACL, then the people tend to use quadriceps. Why? MCL supports hamstring. MCL comes here ना, ऐसे आती है MCL, इधर से आती है. Sorry, hamstring will come like this. So if you take out the hamstring and MCL is also torn, then laxity will happen because once we repair the MCL or we reconstruct the MCL and we take out the hamstring as well, then the failure rate of MCL will increase because hamstring supports MCL. That's why when there is MCL injury, people either take quadriceps or patellar tendon. That depends upon the injury. To take out the quadriceps, we need this. So I'm going to show you a few of the websites. This is an Arthrex website. It's an American company which around number one for the knee sports injuries. So we go to the cruciate injury, then ACL reconstruction. Here you can see quadriceps. So we will only be doing quadriceps. So we will take out the quadriceps through this quad pro tendon harvester. There will be only single piece of quadriceps which will be. The button of quadriceps is known as FiberTech tightrope. So hamstring buttons are different, quadricep buttons are different. So hamstring tendon was 7 to 8 mm. This I can take up to 10 to 11 mm. So it will be more thicker and more stronger than hamstring. And it is predictable. Predictable means I can choose what diameter I need. If there is a female, then we'll take out around 9 mm. Patient is less than 6 feet, then 10 mm. If it's more than 6 feet, then 11 mm, depending upon the knee size. There will be a small incision on front of your knee and we'll take out. Whatever I will take out will regrow. So this is quadricep tendon harvester. Development doesn't happen only in one direction. We will take out the tendon which is 10 mm of diameter, but I will make hole only 3.5 mm. So you will have less post-operative pain. There is a difference between a screw hole and an all inside. So this is known as all inside. All inside means that you will have a less pain after the surgery because that bone damage is less. So we have now adjustable button systems. So many buttons comes for quadricep tendon, hamstring tendon and patellar tendon. So we will be using 2 adjustable button system of quadriceps. Sometimes people use a fixed loop device which is known as endo button. So we are not going to use the endo button. The endo button is fixed loop device. All inside means that we drill the tunnel with the flip cutter. Open the flip cutter. So flip cutter on the femoral side, flip cutter on the tibial side. And then? So there will be less post-operative pain. That's the only benefit of all inside. Button are adjustable. Button lagne ke baad, if you pull these 2 threads, this is getting shortening. So both the systems are adjustable. We cannot put a screw here, it's too small. So we'll put a button. This tendon is also going to take 6 weeks to unite to the bone. So instead of the brace outside and giving you a walker, we will put an internal brace. Internal brace needs anchor the fiber tape and 1 anchor. This anchor is important. If you don't put an anchor, then the internal brace can get loose. But once I put 2 adjustable systems and an internal brace, then I can achieve bending from day 1. So when you achieve bending from day 1, there is a less chance of post-operative fibrosis and stiffness. So you can bend your knee from day 1. You can walk without walker, without support. So if you don't have a meniscus tear with ACL tear, then essentially you will be normal within 15 days. Internal brace is going to increase your rehabilitation by 50%. So running will come within 3 months. There is strong data that this is going to be weak for 6 months, any graft. So if fell down in the period of 6 months, then a chance of graft loosening and re-tear. So internal braces prevent that thing also. So 88% reduction in re-injury and re-rupture rate if you put an internal brace. We can see this data in one more website known as Mackay Clinic. So there is research by Patrick Smith that shows 88% reduction in re-injury and re-rupture rate if I use internal brace. This fiber tape, the internal brace is coming from the femoral button.
Continue.
From the femoral button, and it is additional fiber tape. By the internal brace, we don't have to use an external brace. So the patient can walk from day 1, bend their knee from day 1. And this internal brace is around 15 years old, not new. I am doing this since I started doing internal brace in 2000. So the rehabilitation will be fast, and there is also a reduction in re-injury. One more ligament is torn in both of you, which is known as anterolateral ligament ALL. That's why they did LET. एक और ligament टूटता है ACL के साथ, that is ALL, and this is torn in almost all the cases. With the ACL injury, this ligament also get torn. Doctor is not doing ALL reconstruction or ALL, then anterior posterior stability you will get, and then there will be slight rotational instability always. This is going to increase the failure rate of your ACL surgery. So most of the good surgeon will do ALL in every case. We now routinely combine this with ALL internal brace for extra protection.
What's ALL, doctor?
I will tell you, sir. The combination of ACL and ALL will give you better result, reduce re-injury and accelerate recovery. ALL is this. So either I can do ALL with the fiber tape, or I can do ALL like they did it in you, in LET with the tensor fascial atta. So I will do with tensor fascial atta because it becomes very reasonable, and there is no difference between the result of ALL of fiber tape or ALL with. In one we are making ALL with fiber tape, in one we are making ALL with tensor fascial atta TFL. So this is only done with the ACL surgery, and the goal of the LET is reduces the residual laxity and reduces the risk of ACL graft rupture. So we will be doing mini LET. So in traditional LET, the surgeon will give.
At Lamere construct.
In traditional LET, there is such a big incision, but we do only small incision here, a mini LET with the practice. And then
The strip.
I will take out the iliotibial band like this. So it is attached from the tibia already. If you don't take beneath the LCL, then it's also equal. There are a lot of studies which show either you take beneath the LCL or you don't take beneath the LCL is fine. Both are equal. There are studies which shows that you can take a middle 1/3 of iliotibial band, or you can take the lower 1/3 of iliotibial band. Both are the same results. If you take a middle 1/3, then you have to stitch it. It increases the surgical time. So I prefer to take the lower 1/3 and then we attach it to the epicondyle, to anchor. So if I do through an anchor, it becomes more safer than a screw. This is an onlay technique. So there is no difference between a result between onlay and inlay. In inlay, we use a screw. In onlay, we
Raise
use
flexion.
anchors. So this is knotless anchor, which makes the job
Pull the
very easy.
tensioning tail of the more proximal loop to cinch the graft down to bone. Gently reflect the IT band graft distally through the second loop. Pull the second tensioning tail to cinch down the distal loop. The excess IT band tissue can be cut 1 centimeter distal to the fixation.
So this is a knotless fixation of LET. Then this is only 40% of the result. 60% of the result is rehabilitation. If you don't do a good rehabilitation, the result will be very bad. So there is a study in the American Journal of Sports Medicine. A 60% result will come when you have a structured rehab, phase 1, phase 2, phase 3, phase 4. So we will call you every week, wherever you live, and we'll teach you exercises every week for 6 months. After 3 months, running will come. And if you don't do 50% chance of re-tear rate, if you don't do the neuromuscular training. So वो आपकी बाकी है. NMT, neuromuscular training, is late rehabilitation. So when everything is complete, then you will fulfill. You have meniscus tear. आपके भी later meniscus tear है. So for the meniscus, we will be using zone navigator. So we will be using zone navigator as an instrument to slide the needle, and we use tape. This is a meniscus inside out, and for the posterior horn, we use all inside fiber stitch. Meniscus tear repair. And in some cases, we put a blood clot in the meniscus. We make a blood clot, we insert the blood clot in the meniscus and then repair it. Meniscus सफेद होता है ना, so it doesn't unite. So I put a blood clot and then repair it. In isolated meniscus tear, we put a blood clot. And with the ACL reconstruction, sometimes there is so much of blood in the joint already, so you need not to do a blood clot.